Welcome to Advanced Nurses. We connect with nurses who inspire other nurses by sharing their experiences. And so we're able to bring that information to you.
Hi, I am the educational consultant with Advanced Nurses at ACD4N, and today I really wanted to talk about if nurses are interested in transitioning into clinical documentation, some things that they could actually do to kind of help them move the process along. So, one of the things I think nurses should do is get a copy of the ICD-10 coding manual. This is from AAPC, but there are other organizations that publish and other companies that actually publish the coding manual. The coding manual is updated every year, depending on the role that you're going into. If you are, for example, looking at doing a retrospective review, which means you're looking at dates of services for that have already been billed, then you may want to make sure that you're using a coding manual for the year that you're reviewing. You may be going back a year or 2 years for educational purposes. So let's say if you're doing a look back because you want to see if there was opportunities to improve the clinical documentation and you wanted to provide education around, services that have already been billed, which is common. You want to make sure they're using the coding manual that is for the date of service being reviewed. Also, learning how to use the coding manual is very important. So, I know many organizations and many folks in CDI that I've spoken to say that they use systems such as like 3M, for example, to help them with the code selection. And essentially, the system is able to read and review that provider's documentation and then pull the codes for the CDI person to do their job. But I believe in tried and true practice of using a coding manual. Now, the coding manual begins with alphabetical index to be more specific. You have the guidelines. You have the alphabetical index. The alphabetic index reads, and looks very much like an encyclopedia. Okay. So everything is in alphabetical order. However, it is in the alphabetic index where you start. The alphabetic index will guide you to where in the tabular, where a lot of people are tempted to go to first. But this is where the codes for all of the conditions lie right here, and you get more specific as you actually go into the tabular. There's also a neoplasm table, and there is also a drug table. And so the coding manual, learning how to use a coding manual will be very beneficial for you if you are using the coding manual to guide you in more specific coding and coding instructions after the use of computer-assisted coding. So that is that. Again, if you decide that you want to practice, I would recommend that you get a exercise book like this where you can do some practice exercises, but just make sure the year that you are selecting for your book, like let's say if you decide to get like an older version from like eBay or get it from Amazon, like a used older version, just make sure that the year of the book that you're using the coding manual for that same year. So this is just my word of encouragement for nurses. If you're interested in learning about ICD-10 codes, another place where you can go to, I just thought about that, is the Association for Clinical Documentation Integrity Specialists, ACDIS. They have an inpatient and outpatient CDI program that I think is really great. I mean, it's kind of cute. You get this CDIA designation that you can use in your email and your signature. But you can also, with this information, get foundational knowledge about clinical documentation integrity. And so I think, again, ACDIS, the Association of Clinical Documentation Integrity Specialists, they have inpatient and outpatient CDI program. It is self-paced, it's completely online, and you have a specific time frame to complete it, but there's exercises that it's a lot of reading. It is a lot to commit to, in the sense where you definitely want to designate time. I love it because I have been able to go back into it so many different times. In fact, when I went after my clinical my certified documentation integrity practitioner certification, I was able to refer to my notes and refer to the program that I completed with ACDIS. So this is definitely a real opportunity for you. Again, with ACDIS's inpatient and outpatient training, you can have a self-paced, opportunity. This is about $300, to get your feet wet in CDI. And also in medical coding, because it goes over coding guidelines and best practices in CDI and query. Now, what is a query? Essentially, a query is a communication tool between the CDI specialist or the clinical documentation specialist and the provider whose documentation you're reviewing. So if it's a physician or a mid-level provider, such as a nurse practitioner or PA, and you're reading their documentation and you see that there's opportunities to improve the documentation. For example, something that happens common in EHR systems, if you look at a patient's profile or like a medical record, you'll sometimes see the problem list pull over from like just a collection. It's like the system is going through and just picking up all of these conditions that were in that patient's past history. And sometimes in the problem list, it could be a list of conditions that it could be tempting to want to code that, or as a CDI, it may be tempted to look at the problem list. Well, the problem list is just carrying over information that has been captured from previous encounters. So you may have a stroke listed there, or even a cancer listed. And let's say in CDI, you see that you maybe there's indication that the provider is concerned or monitoring something related to the stroke, and there may be some temptation to code or to capture the stroke code. Well, you don't want to be capturing conditions that are not current at that date of service. So, for example, stroke is a very common one. In most cases, it is the late effect of the stroke that the provider in the doctor's office is taking care of. Now, in the inpatient setting, it would be okay and expected for you to see that stroke diagnosis there, because that could be a condition that would bring a person into the hospital and admitted and found after study to be the diagnosis that led to that admission. And so that would be appropriate and expected in inpatient. But if you see that when you're doing a chart review in the outpatient setting, that should be like a red flag. You're like, wait a second, this person had a stroke, and then you're reading the provider note, and the provider documentation is just talking about, patient will continue on with physical therapy for left-sided weakness. And so that would let you know that stroke is not a condition that we need to really look at. We need to be looking at the hemiparesis, okay, and the specific documentation for the laterality, if it's left or right, if it's upper lower extremity. So, or if it's non-dominant or dominant side, for again specificity for the coders, right? And cancer is another one. In nursing, we used to, sometimes we write it too, but we're used to seeing providers write, history of cancer. And oftentimes we use that language just to say that the cancer is present, right? That they have a medical history. The patient has a medical history that includes cancer. Well, for coders, they read that as this is a past history of cancer. And so therefore a CDI specialist would query the provider here. So for example, if the provider lists in the different sections of the documentation, so we know about SOAP notes as nurses, right? So subjective, objective, assessment, and plan. So in the assessment section, where most coders start the process of coding for a visit, they see that history of cancer. We want to make sure within that documentation that we're talking about something that's history, because there's a code for history different than if this patient actively has cancer. So where are the indicators in that note that this condition is current, right? So before assuming anything, it is best to query the provider for the clarification. There are ways that you can go about this. Some coders may just go straight to coding the history and they may not necessarily look at the rest of the encounter or the rest of the documentation, because they may not be comfortable with the terminology, right? So maybe they're not comfortable with the medications, maybe they're not comfortable with the terminology, and therefore that history of cancer is going to be coded just the way the doctor wrote, which is within the scope of the coder. They're going to write it. They're going to code it exactly how the provider documented the diagnosis. So CDI, what we would do is we would look at the indicators of this condition being active, and as a query, a compliant query, we would reach out to this provider for clarification. Is this condition present? If we see indicators, for example, maybe a provider sent the patient out for a consult or from some type of blood work or study, we could ask the provider in the query, you documented that this patient has this. What is the significance of these studies, this test result, this lab result? And so, or this consult, right? What is the rationale for it? Or what is the significance? What were you looking for? This will jog the provider's memory so the provider can go back and say, oh, you know what? I think I remember that patient, right? This is my train of thinking, right? So this is my decision-making process, right? And that's another thing too. Providers should, after you're working with a provider, and something that most nurses know, providers have ways that they approach things, right? So their decision making, right? The way they think about arriving to their diagnosis. Now, as a clinical documentation specialist, you're not going to tell the provider how to arrive to their diagnosis. But what you're going to do is you are going to highlight for that provider the studies that this provider, again, if you're getting comfortable with the provider, you may actually know where that provider is going to. But it is not your job to tell the provider how to diagnose or to treat or manage a condition. It is your job to encourage the provider to pay attention to the details of his or her documentation so that the coder can code with specificity, right? We don't want active cancers to be coded as history of cancer. Same thing with diabetes, which is a very common chronic condition. We don't want diabetes to be listed as having no complication when there is a known complication for the diabetes. But the only way we can capture this kind of information is if the provider is specific in his or her documentation. And so the coder can now code with specificity that there's a current complication of the diabetes, which most often is the case because the documentation is supporting that. So again, if you're interested in clinical documentation integrity as a way for you to transition away from bedside, I would say, please purchase the coding manual. Now, if you're really excited about it, you can go to the CMS website and download the official coding guidelines. They're updated and published on the CMS website every single year. It's updated.
We want to hear from you. Schedule a free consultation or send us an email at advancednurses@acd4n.com or visit our websites www.advancednurses.info or www.acd4n.com.